I have a long experience with midostaurin because I participated in the initial single-agent trial in relapsed refractory patients. I participated in the trial in which we combined the drug with chemotherapy, and obviously participated in the ratified trial, which was a randomized trial. I think it should be a new standard of care for those people who fit the approved indication. Again, those who are between age 18 and 60, maybe older, who are getting chemotherapy, who have a FLT3 mutation. There are plenty of other issues that need to be explored. Number one, can we improve upon the results with chemo plus a FLT3 inhibitor like midostaurin? I would say we need to try to do that. The role of transplant, should we be giving it after transplant? Yes, I think we should in the context of clinical trials, certainly, and maybe not. Should we be transplanting everybody with a FLT3 ITD mutation? I would say the results from the ratified trial support doing that, even though that wasn't a specific question that was going to be answered. It's still muddy about whether you should transplant a FLT3 TKD patient, but I would at least consider it. So I think we have some new standards to look at, i.e. giving the midostaurin the way it was given in the ratified trial to the people who would have been eligible for that trial. But we have, as all good research does, more questions now than we did before midostaurin was approved. That's a good thing. There are many other agents in this class of FLT3 inhibitors that are being developed. One of the first ones was a drug called lusartanib, which was subjected to a randomized phase 3 trial in relapse patients of standard chemo for relapse, which is either high-dose Ara-C or mitoxantrone etoposide with nothing or with the drug. It was a negative trial. It didn't impact complete remission or survival, but many of the patients were shown by Dr. Levis not to have adequate levels of the drug in their blood to inhibit the enzyme, so that was maybe a reason that it didn't work out. That drug has also been tried in an upfront setting by Dr. Burnett of the MRC of the UK. We'll have to see what those results show.
I mean, currently, what we try to develop, the companies and the investigators like me, what we are trying to develop to treat patients with AML is to target something that occur in AML development. And this something could be mutations, like FLT3 we just discussed, and there are other gene mutations. So there are other targeting agents which target a specific mutation. The most developed, probably, and the most exciting at the present time are IDH mutated protein inhibitors. So these agents are very effective in early trials to target patients with IDH1 or IDH2 gene mutation. And this is certainly a very promising field, very close to what has been done with FLT3, with respect to FLT3 inhibitors. But there is other way to target leukemic drug, not to target a mutation, but to target a pathway, for instance. And which is really important and exciting currently is to target apoptotic pathway, because leukemic cells frequently have anti-apoptotic signals, require anti-apoptotic signals. So there is a lot of new drug and molecules that are currently developed to try to target protein like BCL2, for instance, or MDM2, or protein like this. And this is another field very exciting. And finally, with respect to what we have done in ALL, immunotherapeutic approaches are really, really important. And antibodies, bispecific inhibitors, and even one day CAR T cells against AML could be very, very important in the next future.